All right, guys, here we go. We're doing second part of this. We're going to really focus on bleeding, which is obviously for shock, hypoperfusion, inadequate tissue perfusion for shock. That is something that we need to worry about. Skip all this. We're going to talk about bleeding, fluid resuscitation. Not really worried about you knowing fluid resuscitation at this point because you're just studying for basic introduction stuff. Okay. Perfusion, circulation of blood within the organ or tissue in adequate amounts. Remember, your blood carries oxygen and also other nutrients in the blood system. If you have a leak in the container, problem with the pump, that's where you're going to start having issues with perfusion. You're not going to be able to get enough. An adequate tissue perfusion, the oxygen, and also on the flip side, carry the CO2 out and away, the byproducts of what the cells have been using. You're going to start having issues. Shock, inadequate tissue perfusion. Doesn't mean that they're not getting enough oxygen. It's not just oxygen. It's also the nutrients that the cell needs. Remember, most cells work on glucose. So it's in the bloodstream. If it's leaking out somewhere that it shouldn't be, it's not getting to where it needs to go. They also talk about lack of blood flow. The cells, organs, enough oxygen, nutrients function properly. Same thing. Inadequate tissue perfusion. Also, on the flip side of that, again, the cells make and have waste, CO2. If they cannot get rid of that, it's going to start causing acidosis. Too much CO2 means acidosis. They're acidotic. And that's bad. That messes with the pH of the person's body. That's bad juju. These are the type of shock that I learned them. One is hypovolemic, fluid loss. You don't have to be hemorrhagic. You don't have to be bleeding. Again, hypovolemic shock can be, when we talked about our pediatric patients, loss of fluid. The vomiting and diarrhea will make them hypovolemic. So it really has to do with fluid loss. But for what we're talking about in trauma, it is absolutely hemorrhagic. They're losing blood. Cardiogenic could be they have an arrhythmia, that the pump is not working correctly. It could be that they have an acute myocardial infarction, and now the part of the heart is not getting enough perfusion. Again, the heart is technically in the musculature of the heart is in shock, and it's not pumping adequately. That's cardiogenic shock. The heart is not pumping blood adequately. It's a pump problem. That's our fluid problem. That's our pump problem. Here is our container problem. Distributive shock usually winds up being that something is causing the body to vasodilate. There are some like anaphylaxis, neurogenic shock. There's actually another slide behind it. We'll talk about that right quick. Also, obstructive shock. There could be things impeding on the actual container or the pump itself, like a tension pneumothorax or pericardial tamponade, which we'll probably go into more when we get into chest trauma. This is how they list some of these out. Hypovolemic, still the same. Cardiogenic is still the same. They've got some signs and symptoms that you can go with. Neurogenic falls under the distributive anaphylaxis instead of septic, but they kind of just broke it out. Neurogenic is going to be where you have like a spinal cord severed and it loses something called parasympathetic tone. Hopefully we'll get into that when we get into spinal shock or spine injuries and stuff like that. Anaphylaxis obviously is going to be an exaggerated allergic reaction. It can cause vasodilation, leading to hypotension, increasing tachycardia, stuff like that. Septic shock is usually it's just the body is not able to fight a pathogen, and it gets ran over globally by the pathogen, and the body's still trying to fight the pathogen, and it winds up vasodilating, and they've got a fever and stuff like that. So that's why it's septic shock. All issues having to do with either the pump or the container or the actual fluid in the container. The cardiac cycle, I'm not going to go into this, but basically, you know what the cardiac cycle is. The atria contract, push blood into the ventricles, the valves close, the ventricles squeeze, and it goes out either into pulmonary circulation or actually systemic circulation, starting with the aorta. One of the things I do want to talk about is something called preload. And how they generate, or what is considered to be preload, is the amount of blood that returns to the heart. So if you're getting good preload, That means that you're preloading the heart. Remember, the atria are there, they do contract, but really the ventricles fill on what's called passive filling, meaning that that it comes in from the venous side, whether it be pulmonary or from systemic, from the vena cavas, and it actually just kind of fills, and the valves between the atria and the ventricles are they're open, and the blood just flows through. The big thing is the atria kind of have what's called an atrial kick, and it squeezes in and contracts in as much blood to load the ventricles as much as possible to give them the maximum amount of blood to be pushed through. Then obviously the valves close, and the ventricles contract to keep backflow from happening. Afterload. So that's preload. Preload is just the amount that's coming back. You want to make sure you have good preload. You want good blood return so it can go through pulmonary circulation and get off gas CO2, on gas oxygen, and come back to the left ventricle. So you want good preload. Afterload. Afterload is the pressure in the aorta. Remember we talked about blood pressure, systolic versus diastolic, top number versus bottom number. The bottom number is the pressure, is the overall pressure in the arteries themselves. That's just the pressure. That's just the overall lasting pressure without blood moving. So that's what your diastolic number is. Is pretty much the afterload, or the pressure that's in the aorta. Now, the pressure can change the further you go down the line. Like when you take it in the arm, it's probably going to be less if you can actually measure it in the aorta. They actually have devices that can do that. With that being said, though, that when the ventricles squeeze, the left ventricle squeezes and pushes blood, it has to overcome that pressure. So that's the top number, is what you're hearing, is the ventricle squeezing and the pressure it takes to go past the point that you're listening to. So in the brachial artery, 120/80, if that's your reading, you're getting 120 millimeters of mercury of pressure coming from the left ventricle to that point. 80 is the resting pressure with nothing being exerted on it. And that's your afterload pressure. And they usually measure the afterload in the aorta. It's not really listed anywhere else. Everything else is peripheral vascular resistance. Because you got to think, the arteries start off in a big aorta, and then they start branching off into smaller and smaller and smaller. The smaller you go, the more resistance you're going to put on it. I know it's kind of hard to imagine, but if you take a big pipe and you start branching off into little pipes, it actually puts more resistance, pushes back a little bit. So that's what preload and afterload are. If there's any questions, you're more than welcome to go ahead and text me. All right. Hemorrhage is discharge of blood from the blood vessels. You now have a container problem. The container is broken, whether it's external or internal, whether you can see it or you can't. It's bad. Now, you don't have to have a hemorrhage or a bleed that's caused from trauma. You can have ulcers, bleeding ulcers. You can have a GI bleed. You can have bleeding for a myriad of reasons anywhere in the body. GI bleed is the most insidious, and it hides blood for days. and the only way you can really tell is you actually see active blood or hematochezia in the stool, or the melena, which is the dark tarry stool, and things of that nature. Your stomach doesn't like blood, so you might have hematoemesis, which is blood being vomited, because once you get a significant amount of blood in there, in the stomach, it doesn't like it, and it'll vomit it up. But usually external bleeding, depending on how bad it is, can be controlled. Usually with a pressure dressing, worst case scenario is a tourniquet. There are hemostatic dressings, we'll talk about that, and pressure stuff like that. So, depending on the injury and where it's located and the amount of force used to create that injury is how bad the bleed's going to be and how bad it is to be able to control it. So let's talk about some types of bleeding. One is arterial bleeding. Obviously, if it's arterial, the artery has been nicked. It will be bright red, pulsating, spurting blood. I've seen several arterial bleeds. They're bad. And what has to happen is typically, they've got to go to some sort of vascular surgeon and actually have the arteries sewn back together. Because what happens when you cut an artery, you cut the artery, part of what the artery wants to do is pull away, and when it pulls away, it shuts down and closes to keep bleeding from happening. That's what it wants to do. If you do an incomplete, usually they're incomplete lacerations, so it's trying to pull away and close, but part of it's still put together. Now you have the bright red bleeding, squirting blood coming out of the actual injury. A venous blood flow, they say it's darker in color. Let me tell you, you're not going to sit there and be looking for color. You're not. But for all intents and purposes, it's a darker red. It's kind of steady and slow. It usually can be reduced with direct pressure. And then capillary blood, which is usually like your abrasions and like what we talked about, road rash on other patients. It's usually just slow. It's kind of an even flow, and it's a lot more easier to control. The bad juju part of this is the internal bleeding. And if you're looking, when you do your DCAP BTLS, and you're looking for contusions, because that's what a bruise is, that's the anatomical term for bruise. If you're looking for contusions, they will be a late sign. They are a late sign. You're not going to see them right away. This is, guys, obviously in the hospital, and he's been there for a minute, and he has bruising that is very notable. You will not have that. Again, I go back to high index of suspicion. You need to be able to see and think that there could be possible damage done that you're not seeing, because bruising is a late sign. Mechanism of injuries for internal bleeding: falls, blast injuries, automobiles, motorcycle vehicle crashes, some of the things we've already kind of talked about. You can have, like I said before, bleeding ulcers, bleeding in the digestive system, ectopic pregnancy, which is vaginal bleeding of any type of sorts, and you can have an aneurysm that ruptures. Signs and symptoms, obviously, are going to be pain, swelling, hematoma. Hematoma is just a collection or a pool of blood. In head injuries, we'll see that you can form a hematoma on your head, usually referred to, also known as put knot. So I'm going to teach you what I believe the book is trying to show you, and then how I learned it. They divide blood loss and shock, for hemorrhagic shock, into different classes. Class 1 through class 4. And for me, it used to be like, okay, this is kind of irrelevant. Compensated, decompensated, and irreversible death shock. That's how we learned that. And I think I've got another slide to show you that. But it gives you some of the signs and symptoms. Usually you're going to be, for compensating shock or class 2, you're going to be slightly tachycardic. You'll probably be breathing a little bit faster. They do talk about UOPs, urine output. Mental status, yeah, mildly anxious. But here's the problem. So let's say you run a car wreck, significant mechanism injury. Patient has no complaints. Patient says, I'm fine, I don't want to go to the hospital. But they're exhibiting signs and symptoms of class 2 shock. Is it because they have an adrenaline dump, which is going to happen? Are they tachycardic because of adrenaline, or because they're starting to bleed out? Are they tachypnic, breathing faster because they had an adrenaline rush, or are they starting to go ahead and bleed out? Mildly anxious. An adrenaline dump kind of revs you up and makes you slightly anxious. Is it because of the adrenaline, or is it because of the fact that they're starting to bleed out? So that's what's really bad. So usually if you're going to have these type of patients, again, a refusal is great and dandy, and going in service is wonderful. And of course, they refused, they signed. But how bad are you going to feel that you didn't spend an extra 10 or 15 minutes on scene just kind of hanging out, thinking like, okay, there was significant mechanism of injury, they're fine, you're not going to see any bruising right away, they're not complaining of anything, maybe some pain in this area, and you don't find anything on assessment, and they're exhibiting these signs of symptoms of compensating for right now because the blood loss has been minimal, because it is all based on blood loss, and you're thinking, okay, they're fine, but then they start going to class 2, decompensating, which means that their heart rates start going to go up, and then it's going to start to go down. That's usually what happens in decompensating. And they're going to get more anxious, confused, air hungry. They're losing more and more blood based on milliliters. Again, keep in mind, you only have 5,000 milliliters of blood in your body, roughly, depending. It's variable, but we'll just say an average of 5. And when they say unit of blood, that's what they usually mean. 1,000 cc's. So here you are, you have less, you're losing 2,000 or more. It's called irreversible shock because you cannot reverse it. It's actually, into going into from decompensated to irreversible. You're not going to be able to put enough blood in there to keep them going. Not saying that it is impossible, but usually irreversible is truly what it means, irreversible. But they call it class 1, class 2, class 3, class 4, and it's all based on the amount of blood that's been lost. Here's how I learned it. I'm going to leave this in here. I'm not going to go over it too much with you. You really need to worry about the classes of shock and the amount of blood loss that's been done. But here you go. This is kind of my way. I just put this in here for you. Substantial loss, obviously, we just saw in class 4 shock. 2,000, 2 pints or 1 liter of blood, which is... 1 liter is 1,000 milliliters, is getting up into decompensating. We're starting to decompensate and go into irreversible. So just 1 liter, 2 pints of blood. A unit, I think, is going to be a pint. I'm sorry. A unit is 1 pint. So you start having this loss, it's bad. Significant MOI, NOI. Just look at your patient. Usually pale, cool, diaphoretic, meaning that they're pale, they're kind of cold or clammy to the touch, and they've got this light layer of wet moisture across them, and it's cold moisture. That's going to tell you that they're in bad way. So you might be able to just look in your general impression of the person and just look that they're ashen or pale, and they look like garbage, and they probably can tell based on the fact that there's a mechanism of injury there that they're bleeding out and they're in bad way. Some areas of interest for bones and bone fractures. The femur can lose 1.5 to 2 liters of blood, which is 1,500 to 2,000 cc's of blood. Pelvis fracture, 2,000 cc's of blood. You can lose inside the thorax for hemothorax, 2 liters of blood or 2,000 cc's. See where this is going? You can actually have a broke bone and not see the bruising and have blood loss and due to the fact that of a broken bone or an area where blood can leak out into a cavity. We use the clotting cascade and the clotting mechanisms to make a platelet, plug the hole, use our platelets, and we do the clotting cascade. We talked about that. There are medications. So if you have somebody that's older and they've fallen in their stroke risk, or they have something called AFib and they're worried about blood clots, so what they'll do is they'll putting out anticoagulants, meaning that they are going to take medicine that's going to delay or stop the clotting cascade. And usually when you see Coumadin, warfarin, Plavix, they're cardiac meds and blood thinning meds that they use to kind of keep and control clots from forming. With that being said is, now they have this traumatic injury, do you think those medications are going to do them any good? Absolutely not. Now they're going to bleed, and even worse. So usually if you see an old person that's got a put knot on their head, you usually want to encourage them to go to the hospital to get checked out. Even though they're alert and oriented times 3 and they're able and capable to refuse, tell them, look, you're on blood thinners. You really need to go get a CAT scan and make sure that there's not any more internal bleeding going on, or you're bleeding somewhere else that we can't see. So, and also hemophilia, where the patient doesn't genetically make clotting factors, they obviously will want to go. I've transported several hemophiliacs before. We talked about the triad of death. I think I put a picture of there. The coagulopathy. Basically, as you're losing blood, you're losing clotting factors. You're also losing red blood cells that carry oxygen and carry CO2. So CO2 buildup is going to cause acidosis, because obviously if you're not delivering, you're not picking up. And hypothermia, they will get cold. And that's because blood is being shunted to the core. When you start bleeding and you have significant blood loss, the blood vessels in your extremities will start squeezing down to try to squeeze blood through the venous side back up, and squeeze down to prevent more blood from coming down to that area. Your brain will sacrifice the extremities to try to maintain the core. So it's called shunting. And so you are obviously going to get cold, and hypothermia is not a good way to go. So you talk about your patient assessment, size up, scene safety, number of patients, consider additional resources. In your trauma assessment, yes, consider additional resources. Tell them you want fire, law enforcement, and you want a helicopter on standby. Minimum minimum, and you want ALS intercept. Definitely an ALS intercept. Primary survey. So there's two ways to do this. You can do the ABC. They say DE. You're looking for airway complications, breathing complications, cardiovascular, where they're not hemodynamically stable with like maybe an obvious bleed, and looking for their pulse rate, rhythm, and quality. Obviously, in the breathing, it's going to be rate, rhythm, and quality. Disability, if they're off a bit, or and exposure, exposing the patient and looking. They have an XABCD. So if you walk up and you see that there's an obvious bleed, like they've got a bleed that just needs to be controlled, or something needs to be going on that is not part of the ABC. Obviously, it's in the C, but you can go to the XABCDE mnemonic. You can go ahead and just deal with the life emergency threat right then and there. Like obvious arterial bleed, blood squirting everywhere. We've got to put a tourniquet on this, or we've got to put clotting factors in this, or somebody's going to have to stick their hand in the hole and push down on the artery and stop it from bleeding. Keep in mind, you shove your hand in the hole to keep it from bleeding, guess where you're going? You're going with them to the OR. So get ready for that ride. So if there's obvious stuff that you can control, that's the XABCDE. So that's in there too. So if you can deal with the emergency life threat right then and there, boom, deal with it. Then you'll do your APU, your ABCD. You're going to make your treatment transport decision. Let me just tell you, probably for registry, every patient is going to be load and go. And then you're going to, as you're looking to move the patient, or you're looking for a sample history, somebody give me something on this guy, because somebody tell me something. I need to know it. Allergies, medications, it's obviously the last time they ate. The reason why they want to know last time they ate is the fact that they may aspirate. That's kind of crucial. And then you're looking to do your head to toe. Talk about the history taking. Secondary assessment. You're looking to get your baseline vitals if you can get some. And in your scenarios, in your rapid trauma assessment, if you called for additional resources, they will give you 1,000 people standing there waiting for your beck and call. Not saying that's incredibly accurate, but it's a bit of an overstatement, but still, it's there. They're going to give you the resources you need. You can go ahead and instruct, this person give me baseline vitals, while you keep moving through your assessment. Remember, the goal is 10 minutes to get off scene. And if you wind up finishing your assessment before someone actually in reality gets vitals, that's fine. Maybe they were able to get a pulse and maybe a blood pressure, but you weren't able to get everything else, that's fine. Get them in the back of the ambulance, get moving, and then get those en route. For your trauma patients, if they are critical, it's every 5 minutes. Let me tell you, more than likely, if there's a compromise with ABC, there's going to be every 5 minutes reassessing. So external hemorrhage, this is the bleeding you can stop, you can control. It used to be like pressure points, like you would, if it was bleeding down in it was bleeding like in the radial artery, you could go ahead and push down on the brachial artery and try to stop the bleeding, and then you could elevate it. They don't do that anymore. And now it's go ahead, move to a tourniquet. Go right to a tourniquet. Do not pass go. Do not collect $200. Go straight to a tourniquet. You can try pressure dressing. You can try direct pressure, which is you holding it with some gauze. And then if that doesn't work, you can try a little bit more, and then try pressure dressing and wrap and really hold tight. If that's not working, then just go to the tourniquet. You're done. Again, use a bulky dressing for any protruding wound, high flow O2, and assist ventilations. If their ventilatory rate is not within normal limits, you need to bag them. You need to assist ventilate. If it's not 12 to 20, now granted, it's 24. I'm going to try a BVM. Does he accept? No, he does not. All right, I'm just going to go ahead and put him on high flow non-rebreather at 15 liters per minute. Does he accept? Yes, good. Go on. Keep moving. Tourniquets, usually they're trying to move the CAT tourniquet, which is a combat application tourniquet. The beauty about CAT tourniquets is you can self-administer them, meaning you can put them on yourself. That is the whole point of the CAT. It's for combat application. It's for the soldier who gets an extremity blown off and everyone else died around him, and yet he can save himself by putting this tourniquet on himself. That's what everybody's moving from. There's other ones. I'm not going to go into them, but I think what we have at the school is the combat tourniquet. That basically you can put it on with one hand. Like you can grab it, sling it through, and then cinch it down, and then turn it with one hand. This is the CAT tourniquet that I'm aware of. They've got the stretch, wrap, and tuck that you can do. I've seen that, but they're all pretty much self-administering. You can make a tourniquet, a makeshift tourniquet. You can take like your bandage and your gauze and stuff like that, and then find like a stick or some sort of straight item that's a levering item. Take it, spin it, and then secure it in place with a bunch of tape and a bulky dressing. They make pelvic binders. They're commercial, so you've got like an open book fracture that you can actually take and wrap around the pelvis and secure the pelvis, because when it fractures, it lays open, it's painful. When you bring it back in the normal position, it actually feels a lot more comfortable for the patient. They do make like rigid splints, which are the ones where like they're not SAM splints, but they're like cardboard, rigid cardboard. SAM splints are the got that metal bendy stuff in there, like Gumby. I don't know if you guys know who Gumby is. Anyways, it's the where you can fold and mold it. They also have the inflatable splints where you can put the splint in there and then you actually blow it up with air from an air compressed tank, and it holds it all in place and won't allow the patient to move it. Just remember also in splinting, if the joint is broke, you secure above and below the two bones. So if his elbow was broke, you do here and here. If the radius and ulnar are broke, you'll secure two joints. So it's either two long bones above for a joint or two joints above and below the actual fracture. Hemostatic agents, also known as what I know it as is quick clot. It's usually, or what you could do is this is all folded up like this in this little back and forth pattern. And what you do is you just take it and you shove. You shove in there, you shove, and then you put a pressure dressing on it and hopefully it holds. And this has got like clotting factors and things of that nature that will actually help form and create a clot. Mass trousers, also known as the PSAG, also known as the pneumatic anti-shock garment, PASG, the PASG. These are not used in Georgia. We do have to check off on these. I will probably just show you how they work, and then we'll call it good. Bleeding from the nose, mouth, or ears can actually be indicative of some sort of skull fracture, also known as a basilar skull fracture, which means that the bottom portion of the cranial vault, the cribriform plate, that palate that's just below the right where the nose is, top of the nasal cavity, bottom of the cranial vault, that can be broken, and then you could actually have things start leaking out. Not only just blood, but cerebral spinal fluid. It can leak out. So it can happen from a myriad of reasons. The digital trauma, in case you're wondering, is actually due to the fact that your nose was in a cavity and it caused it to bleed. High blood pressure. People do have nosebleeds, and it's typically because they have weak vessel walls, and they also have high blood pressure. That will cause a nosebleed. For a nosebleed, it's also known as epistaxis. That's a nosebleed. Lean forward. Don't let it drain back into the stomach. Otherwise, they will vomit. One of the things that you can do, this right here, I know it's hard to see, but if you pull up your own and look at your own, there's blood, but looks like there's like this halo around there. That's cerebral spinal fluid. So what would have happened is you would have gone and taken that, see blood in the ears. Obviously, that's a lot, and it might be running down from a facial fracture, so maybe running in the ears, so you may not know. You may have to clean this out to see. The bad part is if that's coagulated and then you just removed it, it's going to start bleeding again. But if there's just minimal blood and it's in the ears and you can obviously tell it's not bleeding from anywhere else, you can take a 4x4, stick it in there, and you're supposed to be able to see the halo test. And what that is there's blood, but there's also cerebral spinal fluid leaking from the ears. And you'll do what's called a halo test. Again, so for internal hemorrhage, you're still working on trying to treat for shock. Obviously, the bleeding needs to be found, especially if you can't figure out where the bleeding's coming from. Nothing by mouth. Keep the patient warm and keep doing your vitals every 5 minutes. Exsanguinating. Exsanguination is also known as completely bleeding out. There's no more blood or not enough blood to be pumped in and around by the heart anymore. So you want to stop that if you can help it. IV access. You want to start working on your crystalloid, which is your normal saline, kind of doing boluses. One of the things that is allowed is called permissive hypotension. You only need 90 millimeters of mercury systolic pressure to perfuse the brain. What the idea is behind and why they started trying to use this is that if you have significant mechanism of injury, multi-system trauma, and you're trying to control the bleeding, is clots may form. They may form. It may take a minute, but they may form, especially if you're able to control some of the bleeding. And so what you don't want to do is you don't want to get them back up to 120 over 80. You want to keep them at that 90 systolic, because what you're doing is it's just enough perfusion to perfuse the brain with whatever red blood cells that are left and nutrients that are left to perfuse the brain. But it's also enough pressure not to blow those clots off and blow them away. So what you're doing is called permissive hypotension. It is very controversial. You need to follow your protocols, but I'm telling you it does exist. And that's it, guys. See you on the next one.